Today we're gonna answer some of your questions, and we're also gonna talk about pregnancy dating. So somebody asked me on Instagram, Dr. Garcia, can you please explain how do we date pregnancies? Is it different if it's naturally conceived pregnancy versus an IVF versus a frozen embryo transfer? And I think this is a great question because it causes a lot of confusion. And
It really does. It is really confusing because you kind of have to suspend belief for a moment.
That's right.
But yeah, I can definitely understand why it causes a lot of confusion. And we actually get a lot of confusion even from other OBs and family doctors. When we're sending out referrals and stuff, there can be a little bit of confusion there too. So it's not exactly well understood. Yeah.
So let's talk about a naturally conceived pregnancy. And let's assume that there's a regular cycle. That means it's 28 days to 30 days. So the first day of bleeding, obviously you're not pregnant because you're on your period. And then 2 weeks later, you ovulate. Then sex happens and pregnancy happens. And then your period is due 4 weeks from the first day of your period. The period doesn't come, you do a pregnancy test and you're pregnant. Great. So at this point in the pregnancy, which is the first time that you did a home pregnancy test, which is the time at which time your period was due, at that point you're actually 4 weeks pregnant. And that's very counterintuitive because you might think, well, 4 weeks ago I was in my period, so clearly I wasn't pregnant. How can I be 4 weeks pregnant? And the reason for this is that's just convention. So the egg that led to that pregnancy, you can think of it was born or it was developed from the ovary, started growing on the day 1 of your menstrual cycle.
So that's a good way to think about it.
Yeah. So if you have regular cycles and you are conceiving naturally and you're due for a period at a regular time and you do a pregnancy test and it's positive, at that point you're approximately 4 weeks pregnant. And then when you do an ultrasound, that's another way of confirming the dates as well. So we measure what is called the crown rump length, which is the size of the fetus, and that would be another estimation of due date.
Yeah. The way I always think about it is that, 100 years ago, back before we had ultrasounds, before we had anything, the one thing that you knew was when the period was and when the period was expected to be. And so that's why pregnancy dating really had to start from the first day of the period, because that was the one kind of recognizable thing, let's say, 100 years ago that people could see, right?
So let's say you don't have regular cycles, and this happens to me just yesterday. Somebody who said, I haven't had my period for 3 months, what's going on? So I brought her in, did blood work, and then there's a positive ACG level. So she was pregnant. She's probably not 3 months pregnant, it's just she didn't have menstrual cycles for other reasons. So then in that case, it's really hard to date it based on a menstrual cycle. You simply can't. And the only way to date it is based on an ultrasound. So it's not always possible to date a pregnancy based on a menstrual cycle when your cycles are long and irregular.
And that's totally normal. Because that whole pregnancy dating is really based on that 28-day cycle, and we know lots of people don't have a 28-day cycle.
So now let's talk about pregnancies that are conceived through IVF. So there is conceived through IVF through a fresh embryo transfer. So that means you take the injections, you do your retrieval, 3 days later after retrieval for a day 3 embryo transfer, 5 days later after retrieval for a day 5 embryo transfer. And then after that, 2 weeks or 10 days after the transfer, you do a pregnancy test and it's positive. So in that situation, you consider the day of the retrieval is ovulation day, and the day of embryo transfer, if it's 5 days, would be a week after ovulation. And it's about the same thing. The moment that you get your pregnancy test positive, you're about 4 weeks pregnant as well. So in that situation, we go by the day of the embryo transfer, if it is a day 5 embryo transfer. And the day of the embryo transfer is approximately week 3 of pregnancy.
Yeah, so it's always a weird one because you're not actually pregnant, you're not pregnant because there's no when the embryo is going in.
That's right.
But it has that, and oftentimes it might not match up with the first day of your last period, because especially in a fresh transfer, the IVF cycle itself may change the length of your cycle or the time to ovulation, and so it doesn't necessarily match up perfectly. But yeah, just by convention.
Yeah, which brings me back to a frozen embryo transfer now. So in a frozen embryo transfer, it could be a natural cycle, it could be a medicated cycle. And again, that could be very long. Let's say you do a medicated cycle, let's say your lining isn't great, you need to be on estrogen longer. So it could be that you're spending 3 3 weeks, for example, in the first part of the menstrual cycle of the frozen embryo transfer cycle before you start your progesterone embryo transfer. So again, based on that, you can use the menstrual cycle either. So then you basically go by the day that the embryo was transferred. So even if the embryo was frozen years ago, you still consider that like a day 5 embryo transfer. And on the day of the embryo transfer, you're 3 weeks into the pregnancy, provided that the pregnancy gets established and you have a positive pregnancy test.
You know, another question I get asked sometimes is, does it matter if it's a day 5 embryo or a day 6 embryo or day 7 embryo? Does that change the dating?
Yeah, it's not.
Yeah, so we kind of assume that when you're transferring a blastocyst, that we basically call it day 5. For the sake of when we're thinking about dating for pregnancy, we just say that they're all universally day 5 embryos.
That's right. For the sake of dating, when we talk about chances of pregnancy, then we do differentiate and we counsel you a little bit differently, or the chances of pregnancy are a little bit differently between day 5, day 6, and day 7. So the other situation that I have very similar to the one I described with irregular cycles is, let's say you have a miscarriage and you bleed from the miscarriage, then the bleeding of the miscarriage finishes, which means it's not a real period, it's just bleeding from the miscarriage. And then there is no next period because you're already pregnant. So again, in that situation, you can't really use your menstrual cycle to date in, and then ultrasound comes in.
Yeah, basically, I mean, in a lot of situations, we're relying on ultrasound. And we're using ultrasound to help us figure out, so for instance, how far along somebody is in that moment, and then doing a follow-up ultrasound to make sure that we're having good interval growth. And that's really what we want to see. That's very reassuring, meaning that, you know, if you do one ultrasound and then you do another ultrasound, I don't know, 10 days later, you want to see 10 days worth of growth between those 2 ultrasounds to really show that, you know, yes, this is a good growing embryo, that the pregnancy is progressing in the way that we expect, and that we can rely on this different dating than what we originally thought.
And that brings me to the last important point I want to make, which is that once the due date is established, and it is well established, either based on your menstrual cycle or an ultrasound, and usually if your cycles are regular, the 2 would agree with each other. So once you have established due date, that doesn't change. So it's very common for people to say, oh, I came for an ultrasound, I don't know, at 16 weeks and the baby was big or small, therefore my due date has changed. And that's not the way it works. The due date doesn't change because we want to measure the growth of the baby. We're constantly changing the due date, then we cannot measure the growth of the baby. So that's important to remember that if at 16 the baby is 2 weeks behind, doesn't mean that your due date is going to change 2 weeks backwards, then we cannot say the baby is small. So it's really important to realize that the due date doesn't change once it's well established, and it's really important to establish a due date, particularly for that reason.
Yeah, exactly. So
because you need to know the growth of the baby and to make some decisions about induction of labor later on as well. Yeah, which is really important. Okay, I think that's all I want to say about pregnancy dating.
Yeah, I think that's a good one. I think it's good to clarify that.
Okay, all right. So questions. First question is, how many embryo transfer does it take on average to get pregnant? Great question, and it's a hard question to answer because it really depends on so many factors. Day 3 embryo transfers versus day 5 embryo transfers, euploid embryos versus embryos that are not genetically tested, embryos from women who are under 35 years of age, embryos who are women over 35 years of age, the quality of the embryos. So all of the things really play a factor. For example, the pregnancy rate from a euploid embryo transfer, that means an embryo that was genetically tested and is normal, it's about 65 to 70%. There is still a miscarriage rate with that of about 10 to 15%, but there's a very good odds that you could get pregnant with your first embryo transfer from a euploid embryo. Conversely, if the embryo has poor quality or is more advanced in development, like day 7 versus day 5, then it might take more than 1 embryo transfer to achieve a pregnancy.
Yeah, there's really no such thing as average, and it really kind of depends on your situation in the embryos.
But I think it's important to know, I mean, I think what this question is getting at is that a lot of people think, I'm going to do IVF once and get pregnant. And I think that's important to know, that it does take sometimes more than 1. In my case, it took 8 embryo transfers. Most people don't take that many, but yeah, it does take more than 1, and even for euploid embryos, it's not 100%. So I think the question does touch on that, and it's important to bring it up.
Yeah, absolutely. And I mean, I think on the flip side, you know, we talk about how amazing euploid embryos are, and they truly are, and they're really phenomenal embryos, and PGT is the best testing that we have of an embryo, but there are many people who fail euploid embryo transfers, and just because you fail one euploid embryo transfer does not necessarily mean that, you know, the subsequent one's going to fail, or that, you know, you'll never be able to get pregnant. And you know, I think those are always really crappy conversations to have when people have failed a euploid embryo, but it's not reason to lose hope. All right, so another question we got: do you recommend any priming, for example, Lupron or Orlissa, for endometriosis patients? So this is a really good question. With endometriosis, I think there's two things to think about. First of all, it's, you know, are we talking about priming before an IVF stimulation cycle, meaning where somebody's going to be taking medications, where we're going to be doing the egg retrieval and making embryos? Or are we talking about priming in terms of before an embryo transfer cycle? So let's say, you know, we've already got the embryos made, but now we're planning on putting an embryo in and planning for pregnancy. A lot of the endometriosis medications can be quite suppressive of the ovaries. And so I would, to be honest, I'm a little hesitant about using priming medications before stimulation, like those kinds of for endometriosis, because for many people with endometriosis, and not all, but for many people with endo, they may have a lower egg reserve or lower egg number already. And so if you're going to give them these medications, you can suppress and end up just getting less eggs, unfortunately, which is really not a great scenario. Sometimes if you put people on these medications, you know, if they have big endometriomas, meaning big cysts of endometriosis, you may be able to shrink them a little bit. That may allow you to get better access at the time of an egg retrieval, but it's not really predictable. You can't even really predict where the follicles are going to grow in an ovary that has endometriosis. I mean, you may find that if your cyst is here, your follicles might grow here, and then it'll be a super easy retrieval.
That's right. Or
you might have an endometriosis here, and the follicles grow here, and then you have a really challenging retrieval. You can't really plan that. Before a embryo transfer, those kinds of medications, I mean, I think that's a good discussion to have with patients in terms of how much their symptoms are bothering them, whether they may actually need surgery instead, for instance, for big endometriomas, whether they may benefit from that, or if they have swollen fallopian tubes like a hydrosalpinx, that'd be more of a surgical thing. But I would sort of say generally, I don't really recommend using those medications for suppression prior to transfer even. And I gotta say, nobody likes being on Lupron.
No.
It's a pretty miserable experience, and so it's a tough one, and you have to be on them for a few months, so it really does delay things.
There was a study published on fertility and astrology that showed that with euploid embryo transfers in the natural cycle, pregnancy rates were the same in endometriosis and non-endometriosis patients. So.
So that's often our go-to, just to try a natural cycle first, hopefully with a euploid embryo without any of the priming medications.
The next question is related. So which IVF protocol do we recommend for endometriosis patients with low egg quality? So that's another good question, and I don't think there is specific protocol for endometriosis patients with low egg quality. Just like Dr. Weiss was saying, there's a lot of factors that go into whether or not you use suppression or not for endometriosis. And then in terms of the low egg quality, there's some studies suggesting that endometriosis can have an impact on egg quality, and some studies suggesting that endometriosis has no impact on egg quality whatsoever. So I think the jury's still out there. In terms of low egg quality, we can use things like growth hormone and supplements, and again, the dose of the medication would depend on the ovarian reserve, and we certainly don't want to overstimulate too much to makes the estrogen level be too high, because there have been, again, some studies suggesting that have an impact on egg quality. So I don't think there is one particular protocol here, but there's a lot of nuances and a lot of different things that go into the equation, into suppression, no suppression, the dosage of the medication depending on your ovarian reserve and your goals for fertility, the use of adjuvant therapy like growth hormone or some supplements as well. The type of trigger that you use also depends on, again, the ovarian reserve, the estrogen level, whether you're doing a fresh transfer or a frozen transfer. So a lot of things that go into it. So it's not like one particular protocol.
No, it's definitely not one size fits all.
But lots of factors.
Yeah. Okay, so another question that we got: does the chance of miscarriage decrease after carrying a baby to term? So this is a really good question. I think this one comes up not infrequently, actually. So kind of depends, as I think that's our answer for everything, for all the questions today. But generally speaking, if somebody has carried a pregnancy to term and then they're going to have, let's say, another pregnancy and they're wondering about the risk of miscarriage, well, one thing we always know is that the biggest risk factor, the biggest driver of risk of miscarriage is the age of the woman, like the age of the eggs. So inherently now, if you're trying for your subsequent pregnancy, you are going to be older, and that is going to increase the risk of miscarriage. So one thing that's really important is the birth interval, right? So if you're having, one child at age 30 and the next one at age 40, then yeah, the risk of miscarriage will be higher just as a function of you being, 10 years older. That being said, the fact that somebody has carried, a child to term, let's say, it does tell us, that things are proven, right? That the uterus has worked and that somebody has been able to carry pregnancy to term, which is generally reassuring, and also decreases the risk of some obstetrical things, like for instance, high blood pressure in pregnancy. Really, still the age of the woman, the age of the egg is still the number one biggest factor when it comes to risk of miscarriage, for sure.
That's right. That's right. I mean, carrying a baby to term is great. It shows your body can do it. And so that's definitely really important. But then, like you say, then you're older and there's other factors as well.
Yep, and you may have gotten some health conditions in the meanwhile. You may have developed high blood pressure, you may have developed type 2 diabetes, and that's all going to affect risk of miscarriage as well.
So the next two questions are related to vitamin D, so I'll mention them together. So how much vitamin D per day should the average person doing IVF take during winter? And if vitamin D plays an important role in fertility, why isn't it tested prior to cycles? So this is really good question. Why don't we test vitamin D levels prior to cycles? So there have been a lot of studies showing that vitamin D is important in pregnancy, specifically in implantation. Some studies have talked about implantation levels of vitamin D. Some studies have talked about equality and the ability to make blastocysts on vitamin D. We know that vitamin D is vital in many other areas like bone health and heart health. And we also know that most Canadians, because of where we live and how little sun we get in the year, are vitamin D deficient. Now, we do recommend that our patients going through IVF cycle take at least 2,000 international units of vitamin D levels a day for the reasons that I just mentioned. The reasons that we don't test prior to cycles is twofold. First of all, it's not covered by OHIP. It's not very expensive, but it's not covered. And the second and the most important one is that we don't know what is the perfect vitamin D level that we need to target in order to improve outcomes in fertility care. As a matter of fact, there have been some studies showing no difference in pregnancy rates in vitamin D depletion versus vitamin D levels being normal. So not every study have shown the same thing. So the evidence is mismatched and it's controversial and it's not clear. That's why it's not part of the guidelines. In order for things to become guidelines and the standard of care, there has to be really good and strong evidence to support that. And right now there isn't for vitamin D in terms of finding the perfect level. I think there's very good evidence to say, yeah, you need vitamin D and you should take it. And it's a very low risk intervention, 2,000 international units a day. It's not going to give anybody vitamin D toxicity. And again, because of where we live, it's a very good recommendation. So it's a very low risk for the patients to do this intervention. But the specific level that we need to target in order to improve fertility outcomes are not clear. And that's why we don't measure them, because we don't know what we're measuring really.
Yeah, that's definitely a challenge, And I think there are some questions in the chat here.
Yeah.
I'm just going to scroll through here. Okay, do you recommend melatonin supplements for fertility? If so, what is the dosage?
So there have been some studies about melatonin supplements, anywhere between 1.5 to 3 milligrams. I think if anybody's going to take melatonin, it shouldn't be taken for longer than 3 months. And it also shouldn't be taken if you're taking thyroid supplements, because it could reduce the impact of your thyroid medication. Again, the evidence isn't very strong for melatonin supplements, so I don't think I would make it a strong recommendation. But I understand that when you're going through IVF cycles, you really want to do everything possible to maximize your chances of success. So as long as you're taking it for a relatively short period of time and not every single day, in a dose of 1.5 to 3 milligrams at night, and I would say the month before or up to 3 months before the cycle, no more than that, and then stop it prior to embryo transfer.
And the other thing with melatonin is that, you know, you have to be careful taking it. So, you know, always a good idea to try it, not like on a weekend night, not when you're going to work the next day, to figure out what time you need to take it so you don't have like that sleepy hangover the next morning, because it does affect everybody a little bit differently. So that's one where you have to be a little bit more careful. You got to play around with it, see how your body reacts to it.
My turn to read the questions. Good morning. Any idea what is the wait time for hysteroscopy at your clinic right now? So here at Markham Fertility Centre, we do our operative hysteroscopy in the operating room at Markham Hospital. And we normally have about 1 or 2 days per month that is divided amongst all the physicians. So if you're going on the OR waiting list today, it could be anywhere between a month to 3 months. I would say, right?
It does vary a lot. Certainly, you know, over Christmas the list got longer because we weren't operating as much in December. There are summer OR slowdowns, so 1 to 3 months is probably a good estimate from the time that you go on the list.
It usually wouldn't be more than 6 months. It would be very rare.
So.
Does IVF stim help increase the number of antral follicles?
So basically in the ovary, you have thousands of little baby eggs, and they're microscopic. And then at the start of a cycle, some number of them will start growing, and then they're measuring, let's say, just under 10 millimeters in size. So now you can see them on ultrasound, but they're still small, and those are called the antral follicles that we can see. So some number are going to start growing at the start of every cycle. Does the IVF stim increase the number of antral follicles? If you do IVF and then you look the following month, let's say, it's not going to increase the number of antral follicles that you'll see. The number of antral follicles that you'll see month to month does vary for sure. You might also get variation between the ovaries. So 1 month you might get more antral follicles on the left ovary, more on the right, and then it might flip the following month. For sure it will vary month to month in terms of what the AFC or the antral follicle count is going to be. Also varies a lot based on the ultrasound machine, like how good of the ultrasound is, because you're trying to distinguish things that you see but that are less than 10 millimeters in size. How well you can see the ovaries. So for instance, some people have ovaries that are just higher and they're just more difficult to see on ultrasound. That's going to make it trickier. Or if there's more bowel gas, that's going to change the visibility, and that's going to change the number of antral follicles that somebody's going to count. But I think one of the things that people, and I'm not sure if I'm interpreting this correctly, but one of the things that always comes up is like, you know, on that first day of your ultrasound and IVF cycle, you see 3 antral follicles. Does that mean that you're only ever going to get 3 eggs in the stem? And the answer is definitely a resounding no. So just because you don't see tons of antral follicles at the start of the IVF stim, you can still get more eggs than that in that stimulation. And so it's, even if that month's number is lower than usual, that doesn't really mean anything, and that wouldn't be a reason I would recommend somebody cancel their IVF cycle.
That's right. You gotta start the medication to see.
Yeah, absolutely.
How the ovary responds.
Yeah. Does thyroid issues affect IVF? If so, what can those patients do to improve their chances?
We do check the TSH level prior to an IVF cycle. If it's very high, like if it's like 8 to 10, then we would definitely want to bring it down. There's a lot of talk about what the thyroid level should be in trying to conceive. Should it be less than 4? Should it be less than 2.5? And we can talk about this for a very long time because there's many different guidelines that say different things. So I think in terms of an IVF stimulation, no, we're not talking pregnancy or embryo transfer. It's fair to say that IVF under 4 is fine. And an IVF under 4, whether it's 3.5 or 2.75 or 1.5, is not going to have really any impact on the IVF stimulation per se. Once we get talking about pregnancy, then we check about the antithyroid peroxidase antibody levels, and that can help guide the level of TSH that we want to target, whether it's 4 or 2.5.
And then I think in terms of the other part, you know, what can you do to improve the TSH? I mean, really, if your TSH is high, you need to go on thyroid medications. That's it. There's no vitamins, supplements, exercise, nutrition that's going to change it.
Can you address immune treatments? What does the evidence say for LIT and Intralipids?
I'm going to say that is a topic that we should definitely talk about, but that is a massive topic. That is a whole Instagram live in and of itself, to go through a whole review of why immune, who needs immune, what it is, how we do it, and then the evidence for all those things.
Yeah, I agree. I think we don't have the time to address that. But I would say I mean, we certainly don't have the time to address the evidence, which is what the question is saying. I would say immune treatment is not for everybody. And I know there have been a lot of talk now about different companies like Fertility is doing immune testing. And while I've been a big believer of immune testing and the role of the immune system in reproduction for a long time, I do think it can be overused. And I think it's important to really understand what it is and what you're doing, and understand how little we understand it.
Yes.
Right? And how little we know about it.
Yeah.
So it's certainly not for everybody. I know I get a lot of patients who failed one embryo transfer or who had like one miscarriage, and they really want the whole immune testing and treatment. Because I understand that desire of never being in that situation again. You know,
Yeah, absolutely.
One miscarriage is one too many. One failed embryo transfer is one too many when you are the patient going through it. But unfortunately, there is some evidence for it, but it's not the standard of care. And that's why we have to be so careful in how we use it, who we use it to, and make sure the patients are very well informed on it, because some evidence, some studies suggest it's very helpful, and some studies suggest that it's not. So you have to really pick the patients well and not apply it to everybody, like vitamin D, for example.
Yeah. And there are potential risks, right? This is, it's right. It's not the standard of care by any stretch. And that's why we don't do it universally or routinely. And certainly we have our own stipulations about who may benefit from immune treatment, but even then it's not a slam dunk. So, you know, there's some patients who have really thought there was an immune thing. We did the immune testing, we did the immune treatment, and then it doesn't necessarily guarantee success either.
Yeah, but having said that, we do need to do a whole live on it, because a lot of people ask, and we keep.
Yes, we do. We do. We need to tackle that one.
And we need to bring Dr. Shannon for that one.
Yes, absolutely. Can you take magnesium bisglycinate during IUI?
Yes.
Sure, yeah.
It's great for helping you sleep.
Yeah.
Muscle soreness.
Oh, is it true that you have more successive pregnancy if a follicle is coming from the right ovary? I've never heard that.
No, I've never heard that.
Yeah.
I can't say I've heard that, so no, I can't.
No, not true. If IVF worked and my thyroid got really low, does early pregnancy throw your thyroid out of whack when previously was in optimal range? Yes, it absolutely can, for sure. That's why we check it with the second beta, because it has to do with the shape of the molecule of the beta HCG, which is the pregnancy hormone, and the shape of the molecule TSH. And they can basically kind of fall into the same receptor, and that causes issues. But for sure, first trimester, prime time for thyroid disturbance. Would you recommend acupuncture to support egg quality /IVF?
Well, what I tell my patients, there have been, again, some studies suggesting that it does have an improvement, and some studies that don't. I would say if you can afford it and if you find it relaxing, and then by all means go for it. Because at the end of the day, when it comes to all of these questions, you got to ask yourself, what is the cost of the intervention to the patient, and what are the risks of the intervention with the patient, which is, again, when we talk about immune, that's something also that we have in mind. And then what are the potential benefits? So again, if it's something that you can afford and it's something that you enjoy and find relaxing, maybe there is a potential benefit, maybe there isn't, but hey, it's something that you can do, so then might as well.
Yeah, absolutely, I agree. I mean, there's no evidence of harm with acupuncture, and the risks are relatively low. I'll tell you a story. So I once tried acupuncture, not for fertility, this is like for knee pain. I once tried acupuncture, and turns out I absolutely hated it. Like, the thought of having needles in me, staying in me, freaked me out so much. Like, I could not cope, I could not handle it. So, like, I am not somebody who should be doing acupuncture because it was not relaxing at all. It was not relaxing at all.
I tried it when I was going through my fertility journey, and I really liked it. I really enjoyed it. I like having my time to sit there. I feel like I was doing something good for my body.
Yeah.
So for me, it was a positive experience.
There you go. And I'm not even scared of needles. I don't know what happened.
Next week we're not here.
Yes.
It's vacation time. And the week after that, we're also not here because I'm going to be away at a conference. Next week, Dr. White's away. And the week after that, I'm away. But we'll be back on the 27th.
Yes. Yeah. So we got 2 weeks off, but we promise we'll be back. We're not taking like a super long break. And maybe we'll even tackle immune at some point.
That's right.
We will tackle it.
No, it's due.
It's due. Yeah.
Okay. Bye.
Bye.